So it's my pleasure to introduce the second speaker. Dr. Mark BELLETRUTTI is a pediatric hematologist at the Stollery Children's Hospital, University of Alberta in Edmonton. He's the pediatric director of the John Akabutu, is that the way you pronounce that? Akabutu? Center for Bleeding Disorders, and is proud to carry on the clinical care of children in northern Alberta with bleeding disorders and other hematology issues first established by Dr. Akabutu. And is also, I guess, the first doctor in Canada who prescribed emicizumab for a pediatric patient. So we will discuss about the emicizumab and also his experience with that patient. And just right after, you'll hear the mother of this patient.
All right, thank you. So yeah, the really important talk is next because you're going to hear about my patient from his mother's perspective. But I'll go over a little bit about how I dealt with this particular patient. So these are my disclosures. And as said, I have one inhibitor patient on emicizumab. Our center, along with our adult counterparts, has one of the emicizumab studies running as well. So, wanted to quickly review the mechanism of emicizumab, how it works, examine the results of the current trials, and then talk about the really life-changing effect that this had on one of our young boys who had inhibitors at our center. There we go. So, emicizumab is a engineered bispecific antibody that replaces the function of factor VIII. So factor VIII's main role in the clotting cascade is to bring activated factor IXa and factor X together to allow factor X to be activated, which then continues down the cascade to eventually generate thrombin. So if you're missing factor VIII, it is very difficult to bring these two factors together. And so emicizumab, or ACE910 as it was originally called, replaces that function and brings together factor IXa and factor X to allow the clotting cascade to continue. And so, as shown here, eventually 10A meets up with activated factor V, and then you generate thrombin and eventually fibrin. And again, depending on the studies where you read, up to 20%, as low as 10%, really it's variable. And that research is still ongoing as to establish what is the true level, but it probably is some individual variation, but 10 to 20% is a reasonable estimate. There's been a number of trials going on with significant results highlighted in the boxes where you have upwards of between 56 to 87% patients with zero treated bleeds during the study period while on emicizumab. Haven 2 was the pediatric study. Haven 1 to 4 were over 12 years of age, primarily in the adult ages with different dosing regimens. And then as far as treated bleeds, significant reductions, as seen Haven 1, 79% reduction on emicizumab versus prior bypassing agent prophylaxis. These were just inhibitor patients. Haven 2 was almost 100% reduction. And then Haven 3, which is the non-inhibitor trial, also had significant reduction as well. So really astounding results that had not really been seen, especially in the inhibitor patients. There were some initial concerns with some unexpected serious adverse events seemed to be associated with high doses of APPC or FIBA. And so that was lessons learned from the initial studies and more careful use of those products with emicizumab from that point. So that was seen in Haven 1 as one of the major serious adverse events with thrombotic microangiopathy and thromboembolic events in those patients. In the pediatric study, again, very low severe adverse events. None of those were thrombotic events or microangiopathy. They were all, some of them were related to having hemophilia with inhibitors, muscle hemorrhage, and then in central line infections, device infections, hemorrhage in the mouth. Someone had appendicitis. So, I mean, just some of these were serious because you needed to be admitted to hospital and have surgery, but may or may not have been associated with the treatment. And no patients in this study tested positive for anti-drug antibodies, but there has been one report of someone developing a neutralizing antibody to emicizumab. to date. There is some early surgical data that has been out there where they had 29 surgeries. This was in Haven 1 and Haven 2. So these are all inhibitor patients. 9 of these patients also received prophylactic bypassing agents to help with their surgery, but 20 of them, with main surgeries being dental and surgeries around the use of their central lines, did not have any, were just managed with emicizumab alone with their regular dosing, and 14 of those 20 did not have any bleeding, whereas 2 had significant enough bleeds to need treatment, but 4 had minor bleeding that did not need extra treatment. They just managed with local measures. So seems to, that 10 to 20% seems to be reasonable for some surgical procedures as well. So my patient, we'll get to the really important stuff now. He's currently 8. He was diagnosed at birth based on family history. He has 3 family members on the maternal side with severe hemophilia A. 2 of those 3 had an inhibitor history as well. So he was started on prophylaxis around 9 months, as we tend to do with our patients. And then by exposure day 30, which was around 16 months of age, his inhibitor showed up, initially around 16 Bethesda units. He was started on fever prophylaxis, which was the practice at our center at that time, and on the usual FEBA dosing. He did okay on this until he developed anaphylaxis to FEBA. It was quite an exciting event. So we started him on immune tolerance at that time with a plasma-derived product. He did well with really his inhibitor going below the undetectable level, but when we tried to do further testing to see what his recovery was, he never got into that normal range that we want with inhibitor patients being above 66%. Testing at that time never showed that, and he did have this low-level detectable inhibitor at times. So I mean, we continued on the immune tolerance, eventually increasing his dose, and that went well for a number of years until he decided to have his inhibitor jump quite significantly, so up into the 200 to 300 range. Where we had him on prophylaxis. We introduced immune suppression in addition to the immune tolerance, and really did not get a great response initially. As you can see there, quite high titer inhibitors. And then we switched him to one of the extended half-life products to do immune tolerance because there was some new data that suggested that that may be a reasonable thing to do. And we did get a transient response. We got his inhibitor down to 4. And then it sort of grumbled in sort of the 11 to 20 range, but was climbing again, and he was having more bleeding with that. And so we did another round of more intensive immune suppression, and again, got a inhibitor titer down less than 1, got his recovery above 66%, 67, I know it's just making it, but that was a victory for us because we had never had that before. And so continued on, and you can see we're already 7.5 years of age. We're 6 years of immune tolerance and kind of having response, but not as robust as we would like to see. So 2018 was a tough start. He had a significant escalation in his bleeding episodes. He had some very complex bleeds. He fell on the ice one day and landed on his line, and so had quite a significant hematoma around the line. And then he had a significant right ankle bleed that was complicated by threatened compartment syndrome and quite intractable and significant pain to the point where we all pretty much had to sedate him at one point in the hospital with continuous opioids and ketamine to be able to control this pain. So we had to make some decisions. Obviously, immune tolerance wasn't getting us anywhere. We had these more frequent escalating complex bleeds. We only had one bypassing agent, which was recombinant factor 7A, and it really wasn't working as well as it used to. And we had failed essentially 3 different types of immune tolerance with immune suppression. So we were able to start him on emicizumab through the compassionate program at that time. It had not received Health Canada approval, so we had Health Canada special access to work through, and working with Health Canada and the company, we were able to get him started in April. So how has it gone? You're going to hear most of this from Leanne next, but basically fabulous. He's had no bleeds since April 2018. We did a dental procedure, had a tooth pulled just with emicizumab. He did fine. We took out his central line in March when it stopped working. He had no bleeding. We didn't need any bypassing agents. So he's done great, and you'll hear more of the story momentarily. Thank you.